Good afternoon, everyone, and happy Heart Month. Welcome to our Bay State Health Heart and Vascular Lecture Series. My name is Heidi Zalai, and I'm a clinical exercise physiologist here at Cardiac Rehab at Bay State Medical Center in Springfield, Massachusetts. We're thankful again to bring you our annual Heart Health Month Lecture Series virtually once again. And in doing so, each of our weekly presentations, so you are aware, are recorded, and they're going to be available for viewing again on our baystatehealth.org website. If you're unable to join for our full presentation or in the future, or if you'd like to share one of these presentations with somebody, you're welcome to join us on the baystatehealth.org website. We hope that this is helpful for those who'd like to continue attending, and for those that aren't able to be here today. You can also register for upcoming lectures in the same area, again, baystatehealth.org. And in the past, just so you're aware of our format for today, we do welcome your questions if you have any questions for Dr. Saadat today. And we will address them at the end of our presentation. You can type any of your questions in the Q&A little icon down at the bottom of your screen with this Zoom. And we just simply ask you to keep your questions pertinent to our topic today. If you have additional questions, hopefully in one of our lectures that are coming up in the next few weeks, they will be addressed with the topics that we're going to have at that time. Finally, you will have an opportunity to provide feedback about today's presentation immediately following this Zoom presentation. So without further ado, I'd like to introduce Dr. Saadat. He is a wonderful cardiac surgeon that we have here at Bay State Health in Springfield. Today, he's going to be discussing the latest advances in cardiac surgery. Dr. Saadat gained his undergraduate degree from Georgetown University and his medical degree from the University of Connecticut School of Medicine. He went on to complete his surgical residency with Rutgers Robert Wood Johnson University Hospital and his cardiothoracic surgery fellowship at Tufts Medical Center. We thank you for your time today, Dr. Saadat, and now I'll turn it over to you.
Thanks very much, Heidi. Really appreciate the opportunity, and thank you to everyone for joining on a busy weekend, this Sunday afternoon. It's a tall order to try to talk about everything in cardiac surgery, obviously, in the 45 minutes we have allotted today, but I'll do my best to give you guys an overview, and really looking forward to a question and answer session at the end to really just try to describe as best I can, what to expect with cardiac surgery, what it entails, and how you and your family typically will fare with it. So without further ado, my title again of this lecture today is talking about everything from coronary arteries to atrial fibrillation and all the advancements that we have in cardiac surgery. So I wanted to start with just taking a minute to discuss what it feels like and what it is as a patient, as a family member, right at that moment that you've been told that you need open heart surgery. I can already tell that you're thinking about, what is my recovery going to be like? Is there going to be pain? What's my family going to be having to go through? What are their thoughts? How can I support them? How can they support me? And how concerning is the outcome? Whether things go well, could it go poorly? All of that I completely understand. And these are things that can add a significant amount of fear, can add a significant amount of stress, not only to you, but to your family and loved ones. So what are you potentially fearful of? There could be pain involved with open heart surgery. The risks, every doctor before every procedure that you undergo, whether it's small, medium, or large, talks to you about all the different risks that can happen. Then there's truly some degree of uncertainty when it comes to how you are going to do with open heart surgery. Are you going to feel better? And what the entire road is going to look like. And that, again, not only is it fearful, but it's stressful. It stresses you and it stresses your family. Whether you're working or retired, it can be a stressor on your job, your occupation, your livelihood. And of course, there's lots of preconceived notions about what open heart surgery really is. I'm sure, you've seen pictures and movies, or potentially had your own families and friends from your own past that have undergone open heart surgery. And these are just a few snippets of what you might be thinking open heart surgery is like. Obviously, the black and white pictures give away that these are somewhat outdated. You can see in the bottom right corner is a picture of really the first heart and lung machine that was ever created to allow the patient's body to be fully supported by a machine that drains the blood from your body, takes it to the machine, gives it all the oxygen and nutrients it needs, and feeds it back to your body so that we can essentially turn off your heart and lungs for the duration of surgery while we operate on it. Bottom left picture there, you see it's a big open heart operation with a big metal retractor. You go in straight through the breastbone and essentially have to spread the ribs to the point of being able to expose the heart to be operated on. So these are really big operation and a huge stressor on your body. But the question is this exactly what open heart surgery still looks like? I submit to you that it's not what open heart surgery looks like today. That's what open heart surgery looked like in the past. So what is open heart surgery now in 2023? We have lots of technologies, lots of updated ways of providing open heart surgery. You can see in the top left picture, it's a very small incision on occasion. You know, there's still times we still need to obviously make a big incision straight down the middle to be able to gain access to your heart, but some operations are allowed to be done through much smaller incisions, either on the side or still in the middle. There's lots of technologies and lots of imaging, advanced technologies, including a robotic device that we can use that you see depicted in the bottom right corner there, that are going to help advance the way that you get your heart surgery and the care that we provide for you. So again, it's not the same as what you may potentially have had a preconceived notion about. Some aspects are, but there are just new focuses when it comes to cardiac surgery and how, again, we tend to fix your heart. So this is, to me, a very important picture. It not only talks about what we as a society of cardiac surgeons are trying to do, but it's near and dear to our home. I don't know if anyone can recognize the two surgeons that are in this picture, but this is the father-son duo, doctors Richard or Dick Engelman and Dan Engelman, who essentially started an enhanced recovery after surgery for cardiac surgery patients here at Bay State Medical Center. Dr. Dick Engelman was a pioneer when it comes to utilizing what we call advanced recovery. And we'll spend a few slides talking about what that actually means. And his son, Dan Engelman, became a co-surgeon with him here at Bay State Medical Center. And he's continued to be one of my partners as I joined the staff and joined the team here in 2019. So it's really been a real pleasure to work with these two surgeons in particular, and along with the rest of my partners that I'll try to introduce you to later on in the presentation. So they are operating together. Again, incredibly unique situation to have a father-son duo spearheading, not only a local cardiac surgery program, but on the international scale of advancing heart surgery when it comes to these enhanced recovery pathways. So what does that really entail? Now, open heart surgery, as we've been talking about, we've focused a lot about what it means to be in the operation itself, but enhanced recovery pathways are really focusing on the important components that are preoperative, intraoperative, and postoperative, three distinct settings that require a lot of focus and attention. So when you're looking at the preoperative components, it's really talking about what we can do to optimize you in the days to weeks before your actual open heart surgery to give you the best chance of having a good, positive outcome and stable recovery. That involves a lot of education. It involves what we call prehabilitation. Smoking and alcohol cessation is a main focus of ours, as is nutritional optimization. Obviously, nothing to eat or drink the night before you go into surgery, but we do give you some carbohydrates to load you in preparation and get your body prepared with the nutrients it needs to withstand the stressors of surgery. And what we call multimodal analgesia initiation, which I'll get into more specifically. When you're in surgery, we're using short-acting anesthesia in hopes of waking you up quite early after surgery. We're using that multimodal analgesia, again, which means different kinds of pain medications to help you get through this and your body to get through the surgery. We're minimizing the amount of IV fluids that people are getting. This no bugs, initially I looked at and thought, well, are they talking about bacteria or talking about actual bugs like bed bugs? No, it's just an acronym that's using and saying you want to keep your temperature normal, keep your oxygenation in the right level, want to make sure your blood sugar is properly controlled, and we are prepping the skin properly so that we're not having any infectious complications. That can happen, but we try to prevent it and minimize it as best we can. And also we talk about the type of sedation and all the stuff that we're going to set you up for in the post-operative period, which is really important. Again, the pain medications that we use, we are focusing very much on getting you off the ventilator. Every patient that goes in for open heart surgery does have to go under general anesthesia, which means you're fast asleep and your body is put on a ventilator to support your lungs with a breathing tube in. And our focus is really on trying to get that breathing tube out as early as we can to minimize complications afterwards. Many of our patients are actually, even as long as they're stable, able to be extubated, or the breathing tube and ventilators taken off, even at the right end of the operation or within the first 4 hours after surgery, which is really important. We want to make sure that everyone's getting early out of bed, sitting in the chair, and walking as soon as possible, as early as the first day after surgery. We're getting out as many of the invasive IVs and catheters and lines and drains that we have in as early as we can, again, to try to get you home as soon as possible. So this is, again, just sort of looking at some of the data that we have been presenting in recent national and international meetings of our cardiac surgeon and cardiology colleagues that are showing that when you implement these early enhanced recovery pathways, you're getting some great outcomes. People are using less opioid or narcotic medications. They're less nauseated. There's less lightheadedness. Their mobility is improved. And there's a much shorter length of stay in the hospital. These are all really important things, not only for us in the medical community, but patients and families. Everyone wants all of these things when it comes to our patients and our outcomes. There's great resources out there that are attempting to just get you prepared and familiar. I think one of the most important aspects of what was considered sort of prehabilitation or the preparation for surgery is dispelling preconceived notions and actually giving you a good, solid foundational idea of what to expect. And this is really like this resource from the American Heart Association, just trying to talk to you about what are you expecting on each of those days after your surgery. So day one after surgery, you're going to feel groggy, confused. Those are all normal. So we want to normalize everything that you're going to potentially be feeling. And again, knowledge is power. It's something that's going to help you. If you understand what you're getting into when it comes to open heart surgery and the recoveries, you will fare better. There's no doubt about that in my mind. Days 1 through 3, and then days 5 through 10, we expect, and when I speak to my patients about what to expect from open heart surgery, I say 5 days is average, actually, after surgery. 1 or 2 nights in the intensive care unit is expected. And if everything goes well, we'll get you home. And that 5-day range is average. If it's really fast and you're ahead of the curve and doing well, and you don't like the hospital bed or food, we try to get you out of there up to day 4 after surgery, even if everything is stable and looks good. And also, if you have any hurdles or any challenges, we may keep you in that 5 to 7 day range. And again, those are all averages. In weeks 2 to 3 and beyond, that means essentially what you're going to be doing at home, because your recovery doesn't stop just in the hospital. It's going to continue on even while you're home rehabilitating yourself. So again, one of the main issues after any kind of surgery, right? And definitely with open heart surgery, is how's my pain going to be managed? And really, there's been a paradigm shift with the enhanced recovery pathways and finding the difficulty and challenges with narcotic and opioid use in our society is, are people going to need even opioids or narcotics after surgeries? What we found in studying this is that previously, there used to be high amounts of opioid use, not only during the surgery administered by the anesthesiologist, but even us doctors were administering it afterwards in terms of helping a patient recover. And it really delayed their post-op recovery. 5 to 15% of patients were even becoming opioid dependent. And that was just unacceptable to us. So now the paradigm has shifted into using multimodal analgesia, which is, again, different types of medication other than opioids that can be used, and it's administered even before you start your surgery to get your body primed and ready to deal with pain. And we found there's just such an incredible decrease in the need for use of opioids that truthfully, we're going to start to turn towards no patient even being sent home with opioids, except under very rare circumstances, because we find with this multimodal analgesia that involves Tylenol, another medication called gabapentin. We use what's called regional nerve blocks after surgery that's administered by our anesthesia colleagues right after the surgery that helps deal with postoperative pain. All of these types of new ways to deal with pain are helping us decrease our opioid use. And it's become just an incredible shift and is really helping everyone, patients, family, the whole, all of society, truthfully, in terms of having less of a need and dependence on opioids. So there are some great resources, again, that you can access. I'm going to try to see whether this will work. It did not work a second ago, but there's a link easily. That's the patient guide that our society, the Society of Thoracic Surgeons, has put out there that's going to help you, and it covers the entire gamut. Now, at Bay State Medical Center, we are providing adult heart or adult cardiac disease, but there's pediatric and congenital heart, so babies that have heart disease and problems. There's lung programs. We do have thoracic surgery, of course, at Bay State Medical Center. And so this has fantastic resources. And I really enjoy this portion where it talks about before, during, and after surgery. And you can use this online resource to access and get lots of information, again, very specific about your particular type of surgery if need be, all right? Another fantastic resource that we offer is signing up all of our patients for this app and feature that's called Seamless MD. That's a really fantastic digital platform that allows you to just track how you're doing. You can interact with your doctors and team regarding how your pain level is, what's going on. There's feedback, Q&A. There's lots of different resources, everything that you would need. I acknowledge that when I talk to my patients initially, when I'm meeting them, and have to talk to you about, you need open heart surgery, I can tell a lot of the times that, the information that I'm trying to discuss at that present time, you may not get all of it at once. And that's appropriate and normal because, I just sort of turned your world upside down, and you have to think about all those issues that we talked about in the beginning of this presentation. All those things come to mind. So any information down to the specifics is available on this app. And again, we have a fantastic multidisciplinary team that helps take care of you throughout your hospital stay that, again, I'm going to describe in further detail, that will help you navigate and get through this process. But again, I do encourage you to use any of these resources. There's other fantastic resources out there as well. But really, we want you, in terms of that pre-operative education role, so that you really know what you're getting into when it comes to open heart surgery. It pays dividends when it comes to your recovery. So let's spend some time just discussing all the different types of cardiac surgery. Again, to do this in the next 20 minutes is going to be a whirlwind, but I just wanted to introduce you to what kind of things we're doing in terms of the common operations and for some of the disease processes that we have. Now, coronary artery bypass surgery that I'm sure you've heard about in terms of bypasses, it's also called CABG as the acronym. It's dealing with what's called coronary artery disease or blockages of your arteries. A lot of times, a lot of cardiac surgeons will call themselves glorified plumbers, and that is truly what we're doing. We are rerouting the blood flow and providing new pipes to allow for blood flow to make it to the heart muscle here. So imagine, I'm not sure this projects perfectly well, but here around where my arrow is, there's a blockage in the native artery that sits on the surface of your heart that provides blood flow to your heart muscle to help it squeeze, gives it all the oxygen and nutrients it needs to work. When that blockage happens, it can cause chest pain and sometimes can cause heart failure, in fact. So what we do is we actually make new pipes. So we take arteries and veins, essentially plug it in upstream, plug it in downstream. So now the blood flow, rather than going up against this roadblock, takes a detour. It goes through a new path of least resistance and gets distributed now downstream from the blockage. So I don't actually have to go in and rotor-rooter or cut out any of these blockages. I'm just bypassing it, hence the name, coronary artery bypass surgery. It is still conventionally done most commonly through a large incision straight down the middle through the breastbone to gain access to your heart. That's technically the way that we are most capable of doing these types of bypasses, depending on the number of bypasses you need in the location. There are sometimes, again, this is sort of just a picture depicting the fine, intricate work of plugging in and making the sewing of these pipes onto each other. Sometimes you can actually use minimally invasive techniques depending on the number of bypasses that are needed. It's usually kept to one particular bypass that needs to be done, but that can be done rather than going straight through the sternum or the breastbone on the side here underneath your left nipple. And also sometimes people are using the robot to do robotic surgery to provide coronary artery bypass. There's also aortic valve disease. Now there's different types. The aortic valve is the main valve that comes off of your heart that connects the left ventricle, which is the main pumping ventricle in the heart, up to your aorta, which is the main blood vessel that then is sort of a tree trunk that distributes the blood to the rest of the body, and all the branches to every other organ, including your brain, of course, is provided blood by this. And the aortic valve can sometimes become dysfunctional. It's usually this 3-leaflet valve that's meant to be a one-way valve that allows with every ejection of this left ventricle for blood to be distributed into this main aorta in only one direction. But sometimes when there's pathology or problems with that valve, you can get either of these two common disease processes. One's called aortic regurgitation, which means that actually these leaflets that are normally supposed to coapt or come together so that it doesn't leak backwards, unfortunately it doesn't come together and you have leaking backwards into that left ventricle. So you can imagine that'd be a problem when that chamber is trying to eject blood, but some degree or some amount of it is just coming right back into it. Aortic stenosis is another very common disease process where you can see here that the valve leaflets are actually not opening as widely as they used to. And that's most commonly because of calcium and degeneration. And that's sort of wear and tear that happens on these valves. Just like any other mechanical valve on Earth, you know, our body's ones typically last much longer than any mechanical one, but they do undergo wear and tear and calcify and degenerate over time. So overall, the way we can treat this is actually by doing what's called an aortic valve replacement. So these valve replacements can be done in multiple different ways. Again, a lot of it depends on anatomy and where the aorta is and how we can gain access to it. But sometimes you have to go straight down the middle again through what we call conventional sternotomy. Sternotomy is the term we use, meaning you go through the sternum or the breastbone. You can also do what's called a mini thoracotomy, which is on the side and going in between the ribs, or just half of the breastbone needs to be used. And again, a lot of that depends on particular anatomy. So there's different kinds of heart valves that can be used. There's metal heart valves, there's tissue heart valves. A lot of times people will say, am I getting a cow or a pig? Because they've done their homework and their due diligence in terms of looking at all the offerings and all the options in terms of aortic valves. It is not truly, a lot of times we don't use the actual valves from the heart of the cow or pig. This one valve in the middle is actually the true pig valve that's being used with a piece of their aorta. These little buttons up here are where their coronary arteries originate from. But most of the time, this valve here that you can see on the right is the casing of the heart, or what's called the pericardium. They derive the tissue from either a cow or a pig, and they treat it, and they then sew it and mount it onto a valve that has a sewing cuff. So this fabric sewing cuff is how I actually perform the surgery, because I'll go in, cut out your native aortic valve, all those 3 leaflets, and then I will sew this fabric cuff right there to where that your native valve used to be. And this beige leaflets will then open and close in a normal fashion and gives a chance again to have, for the next, foreseeable future, a good functional valve. These valves, if you use a tissue valve, can degenerate and undergo wear and tear over time. Their average lifespan is about 10 to 15 years. The metal valves do actually last for what we think forever. There is no wear and tear on the metal valves, but it does come with the caveat that you have to be on a blood thinner like Coumadin. But if for people who are either not interested in open heart surgery or not a candidate for open heart surgery, there's great advancements in doing what's called a transcatheter aortic valve replacement that does not require open heart surgery. This is actually for anyone who's ever had a cardiac catheterization, which is a procedure where a cardiologist goes in and actually shoots pictures by injecting dye into your coronary arteries. It's a pretty straightforward procedure. There's always risks to everything we do, of course, but it takes about an hour or two. And this procedure is as benign, if you will, if I can use that term, in regards to what your body has to go through. It's similar to that kind of procedure. So this transcatheter aortic valve replacement has really, over the past 20 years or so, revolutionized how we can replace an aortic valve. I'll show you a video. These are all the different types of valves that are there. And again, the experience when it comes to doing a transcatheter or minimally invasive type aortic valve replacement is just an hour or two procedure that only requires 1 or 2 nights in the hospital, and it's a very small pinky nail size incision, typically in one or both groins. So let me just show you, and again, bear with me as we go through YouTube here. Hopefully we don't get blasted with ads. So this is a depiction of bringing this device up from the femoral artery, which is the pulse in the groin. This is actually showing it going up with a balloon first, which we sometimes use to make a little bit of extra room. As you can tell, we don't have a way with these transcatheter aortic valve replacements to go in and remove your native valve. But what we're actually doing instead is we're using the metal frame of this. As you can see, it's coming up here through the femoral artery, again, going up backwards through the aorta. We stop for a moment in the aorta and we load and set this crimped up little valve. It's crimped up like a little cocktail umbrella, and it's placed on a balloon. And then we travel up again through the aorta and make our way up to the position we want it to be in the aortic valve, which is right here where you can see this wire going through. So this aortic valve, then again, these calcified leaflets are going to remain there, but they're going to get smooshed out of the way and just pushed up against the aorta. In fact, the calcium and disease that's here on the aortic valve is what gets stuck to the metal frame of this device and lets it get stuck in place and stay exactly where we want it to, so it doesn't move around with every heartbeat. So again, as you see here, we're perfectly trying to position this valve. And once we do, we sort of freeze the heart, and then that's how we then expand the valve. And you can see these beige leaflets that are there in the middle are then going to start to flutter open and close. And that's how we actually will replace your aortic valve. Again, we're not going in like open heart surgery and cutting out your old valve and sewing in a new one, but we're just pushing it out of the way. So it's a great new way and technique that we can use to essentially replace the aortic valve without requiring open heart surgery. The aorta itself can also become diseased. There's many entities in terms of the aorta, the blood vessel itself, that become problematic. Two common ones are an aneurysm, which essentially means a ballooning or outpouching of your aorta, or a dissection. There are layers to the aorta. It's a 3-layered tube. And if there's a tear on the inner layer of this aorta, it can cause what we consider a surgical emergency, which is crushing chest pain that radiates to your back, typically right between your shoulder blades. And that tear is something that we need to then replace. Now, this is just depicting what it's like to replace an aneurysm, but for all intents and purposes, the surgery is the same in terms of having to replace that piece of aorta with a graft, typically a Dacron graft that we use. That does typically require open heart surgery. And again, these pictures are just depicting the different portions of the aorta that can be replaced when we do open heart surgery. These branches up here are actually the branches that feed your brain and your arms. So these sometimes also have disease, whether it's a tear or the dissection, or also aneurysm or ballooning or outpouching of the blood vessel. These may also need to be repaired or replaced, which is part of the scope of what we do. Now, a certain portion of the aorta, which is just beyond, if you imagine the aorta being a candy cane, it's that start of the bottom part of the long portion of the candy cane, just beyond where those blood vessels that go to your brain and arms are. And this can actually be treated with putting a graft in, and that is very similar to the sort of concept of what we just saw with the
Sleep better tomorrow night with a new mattress from Framer and Flanagan. Shop all the top brands.
I'll have to invest in YouTube premiums soon, so I don't have one of those commercial advertisements, but forgive me for that. But this idea is that we can actually go in through the femoral artery, again, or the pulse in the groin, and you can deploy this stent graft that will then abut the actual aorta, and it gets stuck in place. And by doing this, you can exclude the area that's either ballooned out or torn with the aneurysm or the dissection, and the blood flow will only go straight through the middle of this graft instead of going into those portions. The reason why these portions, either whether it's aneurysm or dissection, is problematic is if there's blood pressure in there, just like a balloon, it can continue to expand or grow. So those are the reasons why you'd want to get those treated. But again, that's an opportunity to have essentially open heart surgery or having a fix of a heart problem without needing open heart surgery. Mitral valve is another valve that's really important in the heart. It's the junction between your left atrium and the left ventricle. And this can also have problems with either becoming tight or leaky, and that can lead to shortness of breath and problems down the line. It's a really common operation that we do to try to deal with most commonly leaky valves. The valves leaflets themselves can either become damaged, degenerated, or just be redundant. And we typically go in with open heart surgery and essentially just repair the valve to look the way it's normally supposed to, which is this type of fish mouth appearance. So I didn't choose to go really in depth in regards to mitral valves and repairs and surgeries that we do. I just did want to let you know one of our partners, Dr. Kelly Wanamaker, fantastic heart surgeon, one of my senior mentors here at Bay State Medical Center, who was a recent recipient of a really just prestigious fellowship where she went down to Lankenau and worked with one of the preeminent mitral valve surgeon, Dr. Scott Goldman, and it really is now bringing some of these advanced mitral valve, minimally invasive, and advanced mitral repairs to Bay State Medical Center. I'm really proud of her and the work that she's done. She is my go-to resource when it comes to dealing with mitral valve disease. There is more advancements when it comes to mitral valve disease. Sometimes if you can't repair these mitral valves, they may need to be replaced. Again, the conventional valves that we use is similar to the aortic valves, where there can be metal valves or tissue valves, but there is also now the use of those transcatheter caged valves as a means of going in and replacing these mitral valves. They're not for everyone. We really use them in very specific circumstances, but again, it's an option and providing additional resources and options for people who may not otherwise qualify for typical or conventional mitral valve surgery. Excuse me. Another great advancement in the minimally invasive realm is the use of a new clip called a mitra clip. So if you have a leaky mitral valve, essentially what we're doing, rather than doing open heart surgeries, we're going in through a vein in your groin, the femoral vein, going in through across the valve and actually placing a clip on the redundant leaky valve tissues so that rather than having a big gaping wide hole here, you're minimizing the degree of leak by clipping the tissue leaflets together. Again, a fantastic advance that's becoming more and more popular. That's really helping out patients either that don't qualify for open heart surgery because of being either too frail or too sick, or also just disease processes that may not be amenable to open heart surgery. We're becoming more and more advanced when it comes to the clipping and treatment of leaking mitral valves. So again, wanted to shift gears. This is again just meant to be a quick overview of all the different things that we're doing in heart surgery. And heart failure is actually a big problem, and we saw a lot of this actually during the COVID epidemic. But there is different ways that we use. Remember that initial pump picture that I had in one of my first slides of that heart and lung machine, the pump that allows the blood to leave the body, go to a machine, get all the oxygen and nutrients it needs, and gets fed back into the body. We have these, what's called extracorporeal membrane oxygenation, or essentially a heart and lung machine. That's a pump that we can use to provide circulation for someone's heart that doesn't work well. So this machine, when we talk about, there's different types of this extracorporeal membrane oxygenation. One is in a vein and artery, otherwise known as VA ECMO, and another one is in two veins, or VV ECMO. So there's been a lot of advances in regards to how we can actually utilize this. And again, here's a picture of the machine there, but there's so many different combinations and different types of tubes that we are using, and the access has actually become, and what I mean by access is which blood vessels we typically use. Either it's in the groin, the femoral artery and vein, or sometimes even in the neck here, we can place a single cannula. And you might wonder, is this picture in the top right here of just a person that's pretending to have a tube sticking out of their neck and walking around? But I assure you that that is actually not the case, because there are patients that we, especially through the COVID epidemic, that needed to have, that their lungs became so bad that they needed to have a machine that was essentially replacing their lungs. Our goal, again, in terms of enhancing recovery and just making people as strong as possible to get through this, we were using sometimes tubes that were just sitting in the neck, and we're trying to get our patients up and moving and walking and ambulating. And again, the goal is what we celebrated, is to get patients out of the hospital. And again, this was just one of our greatest victories when it came to actually getting patients from this lung replacement machine and using a machine to serve the purposes of providing oxygen to their blood and providing them their, an external source or a machine as their lungs, and getting them home to their family and loved ones. There's other types of pumps that are out there for patients with heart failure. If someone comes in with a massive heart attack, there was a time that we couldn't support those patients. And even if we got them, through their initial heart attack, the hearts just took on such damage and such a hit from the heart attack that it wasn't survivable. But some of these pumps are actually providing some incredible, sort of external support for a heart that's weak and needs some time to recover. So this is an Impella device. It's a new device that goes in through the groin, through the femoral artery, and also sometimes can be placed through an artery underneath your collarbone, and sometimes even directly through that main aorta. And you actually are putting it across the aortic valve and sitting in that left ventricle that's supposed to be the main pumping chamber of the heart. So when that chamber becomes too weak to support your body, this machine will actually take blood from the chamber and it ejects it on the other side of the motor. It's essentially a motor propeller that ejects the blood and takes the place of a weak left ventricle. Again, as I mentioned, it can go in through your collarbone, sometimes directly through your aorta. And there are patients that are put on this device, and we get them up and walking and moving and trying to improve their conditioning and mobility so that they have a better chance as their heart is recovering to not have other hurdles or challenges, things like blood clots in their legs or pneumonias or other problems that can happen from being sedentary and just the overall deconditioning that your body takes from being laid up in bed. We're trying to get even just advances in the technologies to really help you to recover from these surgeries. Now that machine, as you can tell previously, this Impella device is something that requires you to still stay in the hospital. Some people whose left ventricle, or that main chamber that's meant to pump, that doesn't work well anymore, some people can have an implantation of a new left ventricular assist device, or LVAD. This is a pump that actually is implanted and it sits in your body, and all that you see is actually a power cord that comes out right in this area and attaches to a battery. And this is what a real life patient looks like. They have a backpack and they certainly need to have some extra batteries around to be able to hold this, but there are patients that have an artificial pump that's sitting in their body, taking the place of their left ventricle that no longer works and pumps, and essentially is able to have a new lease on life, an extended life expectancy with this new device that goes in. There's other issues with the heart in terms of having arrhythmias or rhythm disturbances or problems. Atrial fibrillation is a really common one in our society. And there are ways that we treat this with ablations, which essentially means that we use radio frequency and sometimes cold or cryoprecipitation. We use cryo to be able to actually freeze the areas of the heart that are generating this irregular electrical impulses. A lot of those are done in a electrophysiology suite, so those are also minimally invasive. Typically, people don't require any kind of open heart surgery to deal with these, but there are a combination or what we call hybrid procedures where we take care of not only the inner lining of the heart, but the outer lining of the heart, and really trying to use these radio frequency, again, what we call ablations, to destroy the tissue of the area. This doesn't actually damage your heart. What it only does is it makes scar tissue and it stops the electrical impulses that are causing the heart's electrolyte activity to go haywire when it comes to arrhythmias. Another problem in the heart, and when especially in patients that have what's called atrial fibrillation or arrhythmia disturbance, is that there are portions of the heart that can become prone to forming blood clot. The most common culprit is this area of the heart that's called the left atrial appendage. As you can see, it's just like the appendix, if you will, but it's a small little outpouching of the heart that in this area, if you have atrial fibrillation, can form blood clots. So what we like to do is we like to exclude or get rid of that area and get rid of the potential for clot to form in this little outpouching. So there are minimally invasive procedures. You can see this device is a Watchman device that's put in, again, through just a procedure where you're numbed up at the skin, you're not even under general anesthesia. They go in through the femoral artery and the vein, and they deploy this device that essentially stops blood flow from being allowed to go into this area and clot off. We also do it in the operating room on people who aren't qualified for that Watchman procedure. We can actually go in, and this is a picture depicting of the actual appendage where we're going in and we're pressing in on it. This is what the heart appendage looks like. And what we can do through these minimally invasive ports is we can actually go in and clip them. So we place a clip just similar to that occlusion device that was occluding from the middle. This area, again, this procedure doesn't damage the heart or do anything. The appendage is what we call a vestigial part of the heart, so it doesn't actually do anything or contribute to its function. All it does is cause a problem when someone has atrial fibrillation. So we actually can go in, isolate that appendage area, and we just put this clip on it so that blood flow doesn't actually go into it anymore and doesn't have the potential to have stagnance in that area and just clot off. So that is something that helps to reduce the risk of stroke, which is one of the dreaded complications when someone has atrial fibrillation. So it's just, again, a really nice new technology, minimally invasive. These things don't typically require any kind of open heart surgery other than these procedures on the heart, but they don't require a big cut straight down through the middle. So I wanted to spend just the last few minutes just talking about Bay State Medical Center. This is what I consider our home in Springfield. Our team, our chief is Dr. Schwan, just an incredible internationally known cardiac surgeon who just speaks on every single meeting regarding coronary arteries, atrial fibrillation, and he's really important in our Society of Thoracic Surgeons in regards to being on expert committees, part of the guideline committees. Just an incredible leader, and I owe him my start of my career, and the way he's mentored me and supported me through the beginning of my career has just been incredible. Again, Dr. Wanamaker, I spoke of early, one of the few female cardiac surgeons around the world. Dr. Engelman, again, with his father, who helped build this program. Also, Dr. Russo, whose father helped build this program. So we have two lineage surgeons that are my partners, whose fathers were also a part of this cardiac surgery program. Dr. Deaton, who also was a founding member of the cardiac surgery team here at Bay State Medical Center, an incredible mentor. And everyone, again, has been just a great cohesive team. But we can't do it without our support staff. We have advanced practitioners that are all part of our team, not only on the floors in the ICU and in the operating room, that help provide incredible care for our patients. This team, again, our outcomes are based on the hard work and dedication of all of our teams. So it's not just the surgeons, not just the advanced practitioners, it's really everyone that's in those. Again, when it comes to taking care of a heart surgery patient, it's not just about what happens in the operating room. It's all about everything from the preoperative care, the intraoperative care, and also the postoperative care. So the cohesiveness that our teams provide when it comes to preoperative, we have to be a part of, working as a team, as with the primary care physicians, with the cardiologists. We have a fantastic care unit that takes care of all of our pre-op patients and gets them prepared for surgery. Intraoperatively, we have specific anesthesiologists who are cardiac fellowship trained, who help us to navigate through a really challenging surgery. We have nurses, we have techs, we have advanced practitioners, perfusionists, tons of people a part of the team that help get you through the surgery. And forget about what the number of people post-operatively is incredible. If you're in the ICU or on the floors and you see our team come by, every day it's filled. It's a huge mob of people filled with nurses, filled with consultants like nephrologists and cardiologists. We have cardiac rehab people. We have pharmacists dedicated to the cardiac team. We have physical therapists and social workers and case managers and teams that are a part of palliative care. That is all meant to help enhance the way we get patients through their surgery and their recovery. Again, enhanced recovery is focusing on not just the surgery. It's preoperative, intraoperative, and postoperative. And it really takes a full village, just like it takes a village to raise children. It takes a village to get everyone through open heart surgery. It's undeniable. So we have our cardiologists as part of our team. We have, again, this is what I consider my home in the operating room. It's a fantastic, newly redone suite with just all the technologies that we need to be able to implement all the new advances that I talked to you about. My home away from home is considered the ICU. We have fantastic newly renovated ICUs there, again with all the teams, and just is all meant to be trying to provide the best care that we can to enhance your recovery, to get you through what we know is a really difficult time and challenging operation and a stressor on you, your family, your loved ones, and your body. And we try to get you through that as best we can with, again, cohesiveness, collegiality, and just expert care. But with all that being said, this is my real home, my family, the people who have helped me get me to where I am today, to be able to help others. I couldn't do this without them and their support, my wife and my children. Just incredible. And again, final thoughts in terms of what to get through and what we're talking about here every day with open heart surgery. What I want to leave you with is that truly you can do it. I know it can be scary, it can be stressful, but you can get through open heart surgery, and you don't need truly just minimally invasive stuff and all the new gadgets. We can get you through conventional open heart surgery. You just have to be, dig your heels in, and we're all going to work together to get you through your operation. Knowledge is power, in my opinion, and most people's opinions. So learn about your surgery, use those resources, ask as many questions as you need, seek answers. I try to tell my patients, reach out to me. 5 minutes of conversation between you and I that can sort of allay any fears or concerns you have is better than you worrying about something for 12 hours as you're sitting there anxiously awaiting your surgery. You and your family are truly your best advocates. So remember, it's normal to be nervous, but certainly do not fear open heart surgery. And again, we are a team. We're going to work together. It's not about me and, it's not just about you either. We're focusing on you as a patient, but we're going to get you through this as a team. We're going to be taking care of your family. We're going to take care of your loved ones, and we're all working together to get you through this. This is a fantastic story of Karen, who got her open heart surgery, and this is stuff that's published on our websites with her permission. But she was out hiking the Badlands 5 months after conventional open heart surgery, so it can be done. You can do great, and again, just find your inspiration. The people that help me wake up every day to get to work and do the job that I do is my family and my loved ones, and use your inspiration to help you get you through your surgery. And again, we'll be there for you. So with that, I think we've run out of time, but there's lots of good resources, lots of good stories out there on our website. And again, the internet can be a scary place, but there's lots of good information out there as well, and it can help you get you through your surgery. So with that, I'll open up to questions. I really want to thank you all for your time. And sorry if some of that felt rushed, but I just wanted to get through as much as I could to expose you to really the new advances in heart surgery and what we have to offer, especially here at Bay State Medical Center. Thanks again for your attention, and hoping to take any questions.
Great. Thank you so much for your time, Dr. Saadat. That was phenomenal. Your visuals were exceptional, and just your explanation, putting such complicated techniques, which we know are very complicated, putting it into a very simple way for everybody to really understand. We appreciate that coming from somebody who we appreciate your knowledge and your expertise in all that you do. Couple of questions that we do have for those that are also looking to ask a question. You can use the Q&A down at I think it's at the bottom of your screen for this Zoom presentation. Somebody asked, how many heart ablations can one person safely have to correct AFib?
Oh, that's a great question. It varies per person. There's different types of ablations, and it depends on how much of the heart was essentially ablated with each session that you have. So there are people that have to go in for multiple types of ablations. The type of atrial fibrillation you have is also a factor when it comes to the success of it. So, we typically try to start with what we consider the least at first, and we use what's actually called MAPS, because the electrophysiologist can actually track the electrical activity of that heart muscle, and they try to hone in on exactly the portion that could be causing some of that haywire and electrical activity. So we try to start with that sort of one, more of a sniping than a general blast of the entire heart, and then you can get a number of other ablations and also go to that hybrid procedure if need be afterwards, if the initial ablations that are minimally invasive that just work on the inner surface of the heart don't work.
Thank you. Another question, how is it decided to either insert the Watchman versus using blood thinners?
Yeah, that's an interesting question. An electrophysiologist is probably the best person to ask that question to. So your cardiologist that's in charge of arrhythmias and electrical disturbances. But, if someone doesn't actually tolerate blood thinners, there's a lot of patients that unfortunately, if you're put on blood thinners, you have side effects from it and other reasons. Either you have bleeding from, your gastrointestinal tract, or even something like frequent nosebleeds can deter your ability from actually taking blood thinners indefinitely. So when that happens, you try to look for other options, and that's what we try to provide with some of these procedures. And again, the rest of the atrium, or that chamber of the heart that is prone to getting clot, it's most of the time in that appendage, but it sometimes depends on what your appendage looks like, the size of it. These are all information that we get from what's called an echocardiogram, an ultrasound of your heart, to judge to see whether we can do that type of Watchman procedure. So it's sort of a combination of both things. If you can't take blood thinners, then we try to look to these other options. But if you can't get the other options, then we have to continue to sort of navigate other avenues to try to solve this puzzle.
That's great. Here's another question kind of piggybacking on that topic as well. If someone has AFib for years, is on blood thinners, is it too late for a surgical approach to help remedy AFib?
Yeah, typically it's not. The nice thing about this is that Yeah, atrial fibrillation, the frequency of it is more in the elderly population. You can actually correlate, a 60-year-old has a certain amount, 70-year-old has more AFib, 80-year-olds have more AFib. So it increases as our population, their age increases. So when you have that, I would tell you that it does not preclude you needing any of these procedures. And again, because most of them are minimally invasive, some of our elderly population can easily qualify for them as long as there aren't other, medical problems that make you too high risk for having procedures. So I'd say more so it's about what your medical profile is rather than your age. You're not too old to get any of these procedures. It's mostly about how healthy you are, truthfully.
Great. Okay. Another question, do you perform atherectomies to unblock heart arteries? And if so, do you mandate implementing a stent after that procedure? And then another part, why would you require a stent?
Yeah, those are all good questions. So the term atherectomy is probably different for a interventional cardiologist than it is for a cardiac surgeon. So an interventional cardiologist is the type of heart doctor that will actually put in stents and unblock arteries from that fashion. I stayed away from that just because it is truly the most common way that blocked arteries are dealt with and addressed these days, but it's all outside of the realm of what a heart surgeon would do. So an atherectomy done by an interventional cardiologist, say you come in and you have a heart attack and there's a blockage there and it needs to be opened up right then and there is, different ways that they go in. They can do rotor-rootering. You can use a balloon to open things up. And then a lot of times, because you are opening up a blockage, a stent will help to maintain the framework. So if you have a blockage that's narrowed and then you've opened it up either by rotor-rootering or by putting a balloon in, you want to use a stent to maintain that frame. So the interventional cardiologists do that. Now, in my world, when I go in and take out what's called an atheroma or take out this blockage, there are times actually that the entire pipe, and I didn't talk about this during my presentation, but if the entire pipe is filled with calcium or clot even, there are times that I, as a surgeon, have to go in and open up that artery, take that stuff out, because if there's no room for me to just bypass it, meaning finding a soft spot above and finding a soft spot below, I actually have to go in and take out all that hard calcified plaque to make room to be able to then find a soft spot to land my bypass on. So a little bit different in my world, but yes, most of the time you need a stent to maintain that framework.
Yeah, amazing. True plumbing, that's just unbelievable. Another question, this is regarding the aortic valve. How is bicuspid aortic valve typically treated and what kind of surgery would be needed?
These are fantastic questions. I stayed away a little bit from bicuspid valve just for the sake of time, but what that means is you have 2 leaflets instead of 3 leaflets, which the 3 leaflets make the typical Mercedes-Benz sign. The 2 leaflets would actually look more like the mitral valve pictures that I showed you, so sort of a fish mouth. So those actually you're born with, and they tend to degenerate a little bit sooner in life than some of the regular 3 leaflet valves. And so we can treat that with either way, meaning open heart surgery or TAVR valve. What we tend to find is that because bicuspid valve patients tend to be younger, what we like to do is offer open heart surgery first for them because we want to actually clear some room out. What I mean by that is open heart surgery allows you to go in, cut out the old valve, and sew in a new one. In the future, a younger patient we expect is going to outlive their valve, meaning the valve will tend to degenerate in that 10 to 15 year lifespan of the valve, and we need to put in another valve. So rather than subjecting you to another open heart surgery, we actually put then the minimally invasive valve inside of the other valve, almost like that Russian doll model where it gets smaller and smaller as you open up the doll. That's the way we are now putting in the valve. So we typically tell people with a bicuspid valve, because they tend to be younger, let's do the open heart surgery first now, and then we make some more room. And when you eventually outlive your valve, we'll then use the TAVR valve. And again, when you're talking 10, 15 years, the way technology has been advancing these days, who knows where we'll be? Maybe we'll put 5 valves in at that time. Who knows? Right now, we're somewhat limited to maybe 2 valves for someone's lifetime, but who knows what the future holds?
Yeah, that makes great sense. Wonderful. Doctor, if you get diagnosed with mitral regurgitation, when should you see a surgeon?
So typically you start with seeing your cardiologist, and a lot of times it has to be designated as severe symptomatic mitral regurgitation. So a lot of people out there have mitral regurgitation. There are people that are in their 30s who have zero symptoms from it. But anytime you are initially diagnosed with mitral regurgitation, that could be found on a murmur by your primary care doctor, or you just get, for some reason, incidentally found to have it through some sort of echocardiogram for anything else. You will then have to see your cardiologist, and when it becomes severe in terms of the degree and also having symptoms, that's typically when you come to see us as surgeons.
Someone was asking about how much does age have to do with surgeries?
Age is a really important factor, but I would tell you functionality in terms of how, there are patients who are in their 80s who could probably beat me in a foot race, and I will be shameless about that. I probably need to be working out more than I currently do. But with that being said, I mean, it's truly a number. The heart itself, in terms of being fragile and frail, an 80-something-year-old heart, you can clearly tell once I open it, has gone through 80 years of wear and tear. But there are many people, it's all about functionality and motivation and, support. And if you're able to, go about your day and you have life that you want to live, we're just going to help you get back on that path.
Great. We have hit our 1 o'clock time frame. Do you have a moment for just a couple more questions?
I'm happy to, if everyone can go through it, no problem.
So this person here is asking, what if I'm a bleeder with von Willebrand type 2M? Do you know?
Yeah, so I'd tell you, for any type of bleeding disorder, we are very close with the hematologist. So typically someone who has von Willebrand's, we will be consulting. Again, that's sort of that preoperative use of the primary care and consultants, as I talked about. So we will make sure that we have a plan in regards to how we would treat that. Sometimes people need to be pre-medicated. Other times we need to know that during surgery, there's risk of bleeding, and that there are different factors and components of blood and clotting factors that we need to use to be able to get you through that surgery. Now, again, anyone with a bleeding disorder doing conventional open heart surgery is more risky, but some of these minimally invasive procedures that really, again, are just pinky nail size incisions in the groin done without general anesthesia, with just local anesthesia, like you're at the dentist office for 1 or 2 hours with a one-night stay in the hospital, is becoming much more appealing for people who have that. So I guess I'd respond to that question by saying, first, let's figure out what you need to have done in regards to your heart and what we need to fix, whether it's a valve or a blockage, and then let's kind of work through it together. And again, it's a team effort, so we'll make sure we have your hematologist and know everything about your history in particular to get you through it.
That's great. This one here is regarding blood thinners and Coumadin, and they're wondering if they still need to take blood thinners after having heart surgery, such as a valve replacement.
Great question. So the Coumadin blood thinner you do need for the metal valve, whether it goes in the aortic position or the mitral position. Any kind of metal valve does require Coumadin as a blood thinner. A lot of patients that are on atrial fibrillation are on different types of blood thinners as well. Coumadin is the only one that's FDA approved for metal valves, but there's other types of blood thinners that you can use if you have atrial fibrillation. So what I would tell you is that the metal frame of those minimally invasive valves does not count as a metal valve. What I mean is metal leaflets. So again, that metal cage is there to get stuck to your native valve, but it doesn't actually require Coumadin. So typically we actually use aspirin, sometimes in combination with another thinner called Plavix, or if you're on a medication for atrial fibrillation already, like Xarelto or Eliquis, we sometimes use aspirin plus those. But again, typically aspirin does the trick when it comes to those tissue valves. So it really is only the metal leaflets that require Coumadin.
This person has had 4 ablations with recurring Afib. Is there anything new that can eliminate the recurring in different locations?
Yeah, I think that's a really challenging problem. I think it depends. I think what we should do is get some mapping done by an electrophysiologist to figure out where exactly the nidus is, meaning the areas of electrolyte activity that are causing your AFib, and have you be seen to see whether or not any of these alternative hybrid type approaches are appropriate for you.
Okay, and this last question here, what are plugs for robotic repair in mitral and tricuspid valves?
I'm sorry, I coughed when you said that. What are what?
What are plugs for robotic repair or mitral and tricuspid valves?
I don't know what the plugs, so the plugs might be for a leaking valve. So maybe that mitral clip
Okay.
that I referred to could be the types of the clips that we use to deal with a leaking valve. Alternatively, there are centers that do robotic surgery to repair these valves that are leaking. So if you need heart surgery, that's not going to be the clip, but you're actually going to go in to have the repair of the valves. It can sometimes be done robotically. We don't have that technology quite yet at Bay State Medical Center, but something that we're going to be looking into in the future.
Okay. Last question is asking about PVCs, which I believe is more electrophysiology related, treating PVCs.
Yeah, we don't have a good treatment for that, at least in the cardiac surgery realm. But if there's a scenario where PVCs, if that ever crosses the bridge into atrial fibrillation, that's something that we could help to address. But we don't have a cardiac surgical treatment for PVCs. And yeah, I agree with you, Heidi. Something an electrophysiologist or even your cardiologist to start with should look at.
Oh, very good. Well, that's all we have for today. So I am very thankful again for your time and sharing all of your expertise with us. That was just a fantastic presentation. We thank everybody for joining us today. We had well over 100 people with us, and I know that hundreds more are actually going to be watching this in the future. So we appreciate everything that you've done today to share with us.
Thank you so much for everything and the opportunity. Really appreciate it. And everyone, just feel free to reach out to me if you have any other questions. Happy to discuss anything.
Great. Thank you so much.
Take care.